It's wonderful being back here, and I had a wonderful day yesterday getting to see a lot of the clinics and leadership and then meeting with everybody last night. What Command Sergeant Major Brock and I want to do is we've got a couple slides to just kind of talk about some of the strategic initiatives that are occurring and give you kind of that political, operational, situational update. But more importantly, I want to have a discussion. So I want it to be interactive. At any time, if I'm talking about something and you want to have a discussion at that moment, that's absolutely fine. There isn't a slide that we have to get through. It's more of a visual just to kind of facilitate discussion. So if we could go to the next one. The reason why I start off with this, and I'm just going to share, is that when we're in Army medicine, many of us don't even understand kind of the breadth and scope of the capabilities that we have across our command. And so our command is the second largest command in the entire Army behind Forces Command. That's pretty impressive. We train more soldiers than any other command in the entire Army, about 38,000 a year. And we have 156,000 employees. Our Medical Research Material Command does about 85% of the research for the entire Department of Defense. It's a $2 billion command, and many of the advances that we've seen over the last 13 years have actually come out of that command. So very, very impressive in that area. So let's go to the next one. So I put this up because what I just told you makes a lot of sense to everybody that's wearing a uniform or civilians that work in the Army. But what I'll kind of go through it, it's probably hard to see for some of you all in the back, but what I found is our biggest threat that I think is out there, and I'll tell you why I think this was the biggest threat, is many people only know or look through us through the lens of a civilian healthcare system. And we are not a healthcare system that's civilian. We have civilians working in it, but we are a military healthcare system that is global across 5 different continents, that has a huge training base, a deployment mission. We're a disability system. We have our warrior transition units, as well as a healthcare system. And we're a huge training and research base. And so what I've done is I've actually put it in civilian speak so we can kind of do a comparison. And then what I'd ask is that when you're interacting with congressional members, or you're interacting with other line leaders, or some of our patients, is to help facilitate this narrative. Because where I got the most concern is when we had the sequestration and the government shutdown, there was not one word on any radio station or any TV station that was concerned about who is going to provide care to our warriors and our beneficiaries. Think about that. The first day when the airline industry was shut down, what happened? Every single TV station had it on there, and in less than 24 hours, what happened? Legislation changed and they were back at work. That to me should have been the shot that was heard around the world, because what it said to me is that people view us through the lens of civilian health care, and that they weren't worried whether or not our beneficiaries were getting care because they just made an assumption they'll get care, but it may not be in a military treatment facility. And so I think what we have to do is really educate people, because the last 18 months we've had 13 different external studies on how much care and what should Army medicine and military medicine be, because of the pressures that we have financially as a nation and the downsizing of Department of Defense and our Army. So what I usually tell people is, when they hear the name Kaiser Permanente, that's a familiar name to most people. We're similar to a Kaiser Permanente. They have about 151,000 employees. We have 156,000 employees. We're about the size of Nebraska for the number of beneficiaries that we support. 3.9 million beneficiaries receive their care from Army medicine. When you look at Cleveland Clinic, because that's another familiar name that's out there, they see about 5.5 million outpatient visits a year. We see about 11.5 million outpatient visits a year. Then if you go down here and you'll see the 100 most wired hospitals, many of our medical centers have earned that award and have earned it for many years in a row. We're also globally connected. We provide telehealth, telebehavioral health, telecardiology, dermatology across 16 different time zones in 39 different countries. So I think whether you got the award or not, we're pretty wired. That's, when you look at the Top 100 Global Innovators Award, that was the award that Medical Research Material Command won in 2012. And so I usually ask people, who do you think, it's a huge civilian award, who do you think were the other recipients of the award? Just holler out. Think about it. Apple, DuPont, 3D, 3M. So think about that. Microsoft won that award. Medical Research Material Command also won that award. The only Department of Defense that won that. Then when you look up here and you're looking at Johns Hopkins and Mass General Hospital, their patient satisfaction is about 85%, which is above the national standard. Our patient satisfaction across Army medicine is about 92%. So think about that. We exceed the national standard, and we deploy, and we have all those other missions that we have. And we do a larger volume than any of the other organizations I just talked about. And then when you look at the bottom, it has in there with MIT, is our Medical Research Material Command has over 600 patents just from that one command. And that reaches out to many of our medical centers and the ISR and the other organizations that are doing innovative work that requires and receives a patent, way more than MIT, almost double what MIT has. Siemens, huge logistics system enterprise, people understand that? We are a larger enterprise system. We are a global logistics system that extends to the battlefield and in 39 countries and across every one of our military treatment facilities. Why do I share that? Because not one of these organizations can do everything we can. That's the important piece of that. So when people hear Kaiser Permanente, Cleveland Clinic, Mass General, they can't take everything that we do. And that's why it's important that we preserve the right capabilities that we will need to support our nation and our war fighters and to be able to defend the nation's freedoms that we do, and we're the enablers that support that. Okay, next slide.
Ma'am, what was the NFL?
Yeah. Oh, sorry. Okay. Actually, Mr. Goodman, Roger Goodell, actually sent us the NFL football and signed it because our whole strategy in Army medicine has little footballs moving down the field, but that wasn't why he gave it to us. But that is what we use as our kind of inspiring logo. We actually have partnered with the NFL, and it's been 2 years now in the area of concussions and really looking at prevention, protection, and detection, and how do we've actually moved into brain health. Because as we look at the performance triad, sleep, activity, nutrition, one of the areas I think is the emerging field in front of us is the health of the brain and neuroplasticity, and how do we know how effective and how strong our Army can be when we start out with a brain that is extremely healthy, and we don't know that. And really that's the piece. So we've had a consortium that just started, and we brought in industry, we brought in our medical academia to partner to really start looking at this emerging field that's in there. And then the other thing that we're doing is actually, I should have put up Major Baseball League, because we're partnering with the Boston Red Sox, so if anybody's a Boston Red Sox fan, we're starting with them first, but we're partnering with them on sleep, activity, and nutrition. And we're working a Healthy Fans initiative, and so fitness, activity, nutrition, and sleep, they looked at what we're doing. We've shared our performance triad, and there's no difference between a soldier and an athlete when you look at the impact of sleep, activity, nutrition, and how that really impacts performance. And so part of what we're doing is how do we target the youth of America? Because right now, 25% of our youth from age 17 to 24 can serve in the armed forces. 75% is ineligible. Think about that. 75% of our youth today are ineligible, and we're not getting healthier as we go forward. So if we don't target right now, how do we improve the health of our youth? I think it's a strategic vulnerability for the future. So that's one of the reasons why we're looking at sports leagues, because our young youth look at athletes the same way they do soldiers, and I think it's an area for us to get our message. So thanks. Okay. This is why we exist. And so we need to make sure we don't ever forget that. We exist to ensure that we have the medical combat casualty care so that young medic at the point of injury is able to give the best fighting chance for someone who is just willing to put their life on the line for our freedom. And then the entire system that needs to support that injured soldier, sailor, airman, or Marine. That's why we exist. So everything we do, we have to look and say, does that give us the capability that we need to be able to deploy and then have the whole entire system of support that's needed to get people back to the maximum level of wellness? So that's part of why we've actually looked at our 4 lines of effort when we look at combat casualty care, readiness of the force, medical readiness of the force, are we ready with our own skill sets, and then health of the force of the family. And we've taken those 4 LOEs and actually have overlaid them on all our military treatment facilities and clinics to really look and say, where should we realign our medical assets that allows us to hit all 4 of those, and then how do we prioritize our funding and our policies and where we put our resources. Next slide. Okay. So that's kind of the major overall that I wanted to talk about, and then we're going to open it up for a lot of questions and answer, but let me give my Sergeant Major a little bit of time to say something.
Yeah, first of all, thank you all so much for being here, and thank you for being so gracious since we've been here. I've been to Fort Bliss, coming over to William Beaumont at least, I'd say maybe twice besides this time since I've been here. And I've seen a lot of growth and change. And I want to thank you for everything that you do on a daily basis. The one thing that I really do appreciate is you take care of our beneficiaries. You know, be nice when they come through our doors. No one really, you know, they really don't want to come here because most folks come to the hospital and it's because, you know, they have some kind of issue. Of course, we're hoping that they're coming for some preventative type checks and health. But be nice and just remember that someone is going to take care of you also. So we really do appreciate what you do on a daily basis. Thanks.
Okay. So we'll open it up for, there's a lot of changes that we're doing in the area of leadership, a lot of changes that we have that is really looking at emerging initiatives in the area of research and where we're looking at graduate medical education programs. So we can open it up to anything that you want to talk about. I'll do this and this, okay?
Yes, ma'am. As you know, I think we have a very special mission here at Beaumont. I mean, we see VA patients, your trauma center, your SRP site, and the BRAC.
Right.
And what I've noticed is a lot of money has been put into building new buildings, building a new Fort Bliss, but I don't see money coming into the AMED for us here to be able to support the size that William Beaumont has grown into. Are we in the near future getting the money?
Yeah.
The resources?
That's a great question. So a couple things with that. When I talked about the 4 lines of effort on combat casualty care, readiness of the force, medical readiness of the force, and then health of the soldiers and their families, those 4 align over William Beaumont very well. So you all meet all 4 of those. That strategy has driven us now to look at all of our medical centers, and we are realigning our green suiters to bring in more capability into our medical centers so that, one, it allows us to improve readiness and health of the force. So I think that piece is coming in here that will really help William Beaumont. The other piece of it is, as you know, we are held accountable for our business plans. We get our money from OSD, and then they really allocate it on whatever this command says is the amount of work that can be done, and then whether or not those targets are met. And then we within Army Medicine have added in kind of the health outcome component where we're giving commanders financial incentives to be able to improve the health outcomes, because it doesn't equate to an RVU or an RWP, but it does equate to where we're trying to move, which is to a system for health. So those two things together, I think, is going to allow you all to move in the direction that you need to be moving. But I have to tell you, it's just because we build buildings doesn't equate to needing to put people on the ground. You really have to be able to have the mission that supports filling out that building.
Thank you.
Yeah, thanks. Good. And I know someone over here. Yes, please.
Camp Cooper, ma'am, Delta Company.
Pleasure.
What is this plan for the restructuring of the TDA for Primary Care and Soldier Readiness Command? I know it's going to be around for at least 2 years, but I think it's very important that it stays a command permanently. When General Doyle started the command, he realized that to organize the footprint and support the warfighter, 1st Armored Division, that it needed to actually be a command. With SRRC and then me coming on as Delta Company commander, actually having a physical presence with the soldiers is very important. So I just bring that up to you, ma'am, to ask what the future is.
Okay, so I'll answer it on kind of 2 levels, if that's okay. I'll answer it first from the strategic, and then I'll take it down to the tactical level. So from the strategic level, we have actually looked across all of our commands, our non-CSL commands and our CSL commands, because we had a pyramid where we had more commands available at the colonel level and less at the 05 level. So it didn't make for, you know, the normal pyramid that you have across the Army on career and advancement. We have actually redefined what is a level 1 command, what's a level 2 command, and what's an 05 command and what's an 06 command. And it used to be that colonels could command 4 times. Colonels can now command 2 times, a level 1 and a level 2. It has actually expanded the number of 05 level commands. So we have much more opportunities. It's going to grow to about 128 lieutenant colonel commands. And prior to that, it was probably, don't quote me, but I want to say 48. I mean, it was a dramatic imbalance. So we have now taken away all non-CSL commands, and we've made them command select list. So we're now more in line with the Army. And then as different opportunities open up, so the scope of your clinics here, when you have a clinic that meets the criteria to be designated as an 05 command, then that needs to just get approved at MedCom, and then that gets put on the list. So we are looking more and more at the other opportunity for advancement. The other thing that I have the team doing, and this will come out, should come out hopefully in the early fall timeframe for me, is how do we give career advancement to all of our corps when a majority of what we do is a clinical mission that sometimes doesn't allow some of our corps to be able to compete for command. But it's imperative that we get to do that. So I asked them to look at and I'll give an example for like a MedSen. Why wouldn't we consider a MedSen a brigade, and then the deputy commander for administration, nursing, and clinical services, why would they not be battalion commanders? Still get selected the way that you do, but be battalion commanders and do the work that needs to fall underneath that. And then your captain company commands would then fall underneath those battalion commanders, so that would align with that. And then what do we do across our MedSens that equates to maybe an S3 job or an XO job, but it's still our regular mission. And we need to align ourselves more with the same terminology. So a clinical section chief, is that really the same as maybe a chief of staff? Is that the same as an S3? You know, they're doing all that analysis for me. But if we don't align ourselves so that we have a better opportunity to then tie the leader development to the schoolhouse and an opportunity to get credit for what we do every day and then make every corps competitive for leader development, I think it's going to be harder and harder for us in the future because we're operating in a joint world. And more it's going to be joint. And if we don't have our terminology really laying out the scope and responsibility, then we're going to disadvantage ourselves. So right now, when people sit on our boards, I got to tell you, they are so confused between all of our corps and the difference between all of our multiple AOCs, and they fall towards what's familiar to them. So we need to change that. And right now, our colonel level commands oversee about 5,000 people. That's huge. But nobody understands that unless you're a colonel level commander, you're working within that command. So we're trying to make that an even balance across the board and give career advancement, and then we're looking the same thing for our civilian workforce. So we have Greg Stevens, our civilian Corps Chief, is engaged in this to look at how do we leader develop and have opportunities for our civilians to actually grow up to the SES level. So that, a long answer, but a lot of work in that area.
Yes, ma'am.
Okay, thanks. Yes, please.
Yeah, Mr. Ortega from the Simulation Center. I'm the Simulation Center
wonderful.
administrator. As you already know, man, we have several simulation centers at different MTFs, different training facilities.
Right.
Throughout the Department of the Army. And I know that we had the CSC that Dr. Deering has been heading for many years, and he's done a very outstanding job doing it. The mission of the CSC, as you have known before, is primarily to support the GME program. But in addition to supporting the GME program, we have expanded, all the MTFs have expanded those services to everyone within the facility, including
Wonderful.
whatever bases we have or forts we have close to our area. I know that we have an MSTC that is primarily, their mission is to support all those units that are going to be deploying. But as we open those doors to additional personnel such as nursing and all the other technical programs that we have here, the mission has expanded tremendously. And even though the mission has expanded tremendously, we don't have some areas, not particularly William Beaumont, some areas we don't have the manpower personnel to do so. And some of the areas that we need additional personnel such as nurse educators that will be able to bridge that gap between simulation and how to expand those services to nursing personnel. I believe that, you know, dealing with my other administrators at the different MTFs, all our locations deal with the same issue, that we have so much to offer to our facilities. However, we are not being
Resourced appropriately.
Yeah, we're not.
Is it not being used or not being resourced appropriately?
I don't think it's being resourced appropriately, ma'am.
Okay.
I think that's the case, and I'm trying to find out, since the mission is already established at the CSC level, and I know that every MTF is given the facility to I guess mold that simulation center to meet their needs. However, the big mission should never change. The mission should continue to be the same, because that's what we're trying to do, standardize all across the Department of the Army. So when the GME doctors, the residents, young residents or interns go from William Beaumont to Tripler,
Yes.
they're going to be dealing with the same kind of equipment, the same kind of manpower.
Excellent.
We want to do the same
Yep.
thing with the nursing personnel and all the other programs as well.
So what you just described at the end is exactly what we're trying to achieve with the operating company model, is how do we have a consistent experience and capabilities and standards, and then standardize where it's appropriately across clinics, community hospitals, and medical centers. And so that analysis is being done, and then what all supports all of those areas. So moving on the standards and standardization, you're moving exactly in the right direction. And then this fall time frame, I'm going to be giving out to all of the commanders and saying these are the capabilities that should fall underneath each one of the deputies, and these are how our organization should actually be aligned so that we have those consistent experiences. And then that's how the training that supports, if it's a MedCen, that's how the training with the GME programs, and what are all the other sources that need to be out there, and then where do we have gaps that maybe we need to have different capabilities to come in and help. So that analysis piece is ongoing. The piece that I want to talk about is resourcing. So the environment in which we're in right now, in which we've been in, is an environment where last year OSD actually gave Army Medicine 80% of Department of Defense cut on the civilian workforce, 80%, because we are 60% civilian, and the other services are way, way, way under that. They're like between 10 and maybe 20%. So we got 80%. If we would have, last December we actually got it reversed, but if we had gone with what they were directing, which was 5,784 reductions in our civilian workforce, what I would have had to do is to close everything we have across Army Medicine except for my medical centers, period. And so what I was able to do is to lay that out and to show and say, this is not an Army problem. This is a Department of Defense, because not one of our platforms takes care of just Army. We take care of Army, Navy, and Air Force, Marine, and Coast Guard. And so if we do this, this is the risk Department of Defense is going to take. And the Vice Chief of Staff fought very hard for us, and we got that reversed. And they gave us back 3,700 and plus civilian authorizations, which was a huge change. And then we were able to, without laying anybody off, we were able to take the other reductions just through attrition that had occurred. But I share that with you because they changed a year ago where I was authorized, and so was every other Surgeon General. We were authorized to hire to the number of civilians we needed based on whatever that mission, if we had the funding. And so we way overhired in many areas because we had a lot of new missions that came about. They changed it to where you could only have towards your authorization, which then automatically made us way over. So before we can hire more people in certain areas, we're trying to right size what's appropriate based on where we're going as a medical force. And based on supporting what are those new emerging missions. And a lot of our TDAs are very outdated, misaligned, and don't at all support the force mix. So that piece is working. We need people to hire, okay? So we're not in a hiring freeze. We are pushing our commanders to hire, but you've got to hire in the appropriate area, and it's got to be aligned to what is supporting that mission. So that work is needing to be done and is being done at all levels. So in the area that you're bringing out, what I would just ask is that as you are looking at emerging capabilities, and what you just described is really a different way to do business. I mean, that's what you're talking. How do we do business differently? That analysis needs to be done, and as we emerge to do business differently, what impact does that have, and what should we change from how we were doing business? And can we realign some of assets to support the new way we're going to do business? Because if we build a new way on top of an old way, we will never be able to afford what we're trying to move towards. We've got to really look and say, how do we realign and change? Does that make sense?
Yes, ma'am.
Okay. Yes, please.
Welcome again.
Thank you.
To El Paso. The last time you were here, we spoke about Beaumont being the center for all of Army, shining light because of the furloughs and the sequestration. I still believe that. We look at the slide, it says Army medicine, Army strong, serving to heal,
Honor to serve.
That is your civilian and military workforce. Those who are in green suits today will be in civilian suits tomorrow. And it's a civilian workforce and the union that is fighting to make sure that the veterans, or the retirees who become the veterans who want that job, still have that right to come here and work. And what we're finding is we want to find out how we can work even stronger with you. We know the limitations in the military, but we need to grow. And we know that there's cuts. We know we're at war, but we also know that we have not reached our full potential here at Beaumont. We can do more with less because of the quality of people we have. We want to know how, countrywide, we can work with the unions to help and make sure that we're exercising all of the opportunities, to making sure that we don't become a VA hotspot. We want to make sure that there are no hidden lists, that we do have every appointment filled and no one's blocking that. And we want to know how we can work with you and how you can work with us.
So we have, we just completed an MHS-wide review that was directed by the Secretary of Defense. And we do not have a crisis occurring across Army, Navy, and Air Force.
Right.
Okay? So, so I think we can put that piece, you know, when people looked at the lens of the VA and was concerned, is that also occurring across DOD? I feel very comfortable saying it is not occurring across Army medicine. Very, very comfortable saying that. The piece that I would say with the union, I think it's imperative that the collaborative partnership is there at all levels, and that we're all in agreement in what's the strategic way ahead and what we're trying to accomplish, and how best to do that in a manner that allows us easy onboarding of our civilians, and that we create and improve and sustain cultures of excellence in the area of patient safety, quality of care, access to care for all of our employees. And that's the piece. I think it's that collaborative partnership, Paul, that I think needs to occur across every area. But we're strong because of the strong capabilities we have within our civilian sector. Yeah, thank you. What other questions, comments? Yes, ma'am.
Hi, Becky Caldwell, Health System Specialist for Department of Surgery. We've got many employees that are, I guess the nice way to say it is questioning.
Okay.
With the development of PCMH, the MedCom standard for grades
Okay.
was different than the grade levels. So we've got a lot of MSAs, LVNs, wondering what they're doing differently than PCMH that makes their grade higher.
Yeah.
I was hoping maybe you could speak to that.
And I wish I could speak well on that. I'll be perfect. I think we've got to go back and look at that, to be perfectly honest, because I've gotten that feedback from a lot of places that I've gone to. The intent when that was developed, the intent was really doing an analysis, and I'm not sure, because I wasn't part of that, what the standards were used, but I know they used standards that were out there. They did an analysis and came up with what they wanted to have as a standardized way so that PCMH, our primary care, which is our funnel to all of our specialties, we wanted to make sure that it was as robust and that it was really the same standards across the board, and then the same allocation of funding across the board when they got the money and then pushed that out. So I know that was the intent behind that. What we have found is that it is causing a siphoning of our inpatient to outpatient, and it's causing a disgruntlement. So I will take that on to relook that. Okay. Okay. What other? Yeah, please.
Yeah, Lieutenant Sutherland, Alpha Company. I'm one of the clinical staff nurses on 9 East MedSurg.
Okay.
Sorry, question. This is regarding 66 hotels. At this time, do not have the opportunity for incentive pay by receiving MedSurg certification. They fill a large variety of roles and are an asset to the nurse corps. They must pass similar testing to receive certification. Is there any thoughts of the incentive pay program being reinstated for 66 hotels?
So let me just make sure I understand this correctly. So you're saying with the ISP program, are you saying that it doesn't apply to med-surg nurses, or med-surg nurses can't get incentive pay until they take the med-surg certification exam?
It does not apply, is what I understand.
It doesn't apply.
Change this FYM and drop straight hotels.
I did not know that. Okay. Let me take that back to the Corps Chief, and because I'm not sure what the logic was that.
It was over strength in the hotel area, ma'am, was
Okay.
impetus. But I agree, it's our bread and butter here.
Okay. Well, I'll take that back. I'll get with General Keenan. Okay. Thank you. Okay. How do you think you all are doing here in the area of patient safety and quality care? And what do you think we can be doing better?
And Major Jason Lang, Troop Commander. So to switch gears
Sure.
altogether, one is the corporate solution for Apex versus
Okay.
DTMS. I know that we're doing that, so I have a vested interest in that one, so
Okay.
I'm curious to see the philosophy from there. And I have a second question is the overall restructure with the rumors that are going on with the regional commands, how is that going to come to fruition?
Okay, that's so y'all are going away. No, I'm teasing. I'm teasing. I shouldn't make light of that because it's been an emotional piece. So let me just, I'll answer your last one first, and then remind me what you said the first one. Okay. So on the MedCom reorganization, as the Army was dramatically looking at what is the Army end strength going to be at 480, 450, 420, does it go lower than 420? And with and then what would the Army look like if it has to go low? Because then there's a second order effect on every single enabler. Because as the Army reduces, it has a reduction of our medical capabilities on the operating side of the force, as well as ours on the generating side, which is, our MTFs, because our soldiers go back and forth. So I was talking with the Chief of Staff, and I thought, if we've stood up the Defense Health Agency and we now have 10 shared services, that landscape has changed. The Army is downsizing and DOD is downsizing. What Army medicine looks like today is not what we should look like in the future because of all the changes that are occurring. And so I asked my team first, I said, first answer the question for me, is a MedCom still relevant? Do we need one, yes or no? And if we do, what should we look like? Are regional medical commands still relevant, yes or no? And if so, what should they look like? What should they do? How many do we need? And then do we have our MTFs aligned and arrayed in the areas that support the mission that we need? So that's what started the Futures Task Force. So they came back, they actually did probably more courses of action than I've ever heard of in my entire career, and I don't say that. 62 different courses of action, 62. They got input from everybody. And then they went down, and then we called in, I asked for retired line leaders. So I had former chief of staffs of the Army and former vice chiefs of staff of the Army, because I wanted the war fighters to actually red team what we were about to do. And so they gave us feedback. And then I brought in graybeards from the Army Medicine to War Game as well. All of that got put in, and then it got worked some more. So this has been about a 9-month project. I just made a decision, and so I haven't announced it yet, but I'll give you I won't tell you what's happening, but I'll kind of give you the concept, okay? But it'll be coming out shortly. So I just don't want to undermine and blindside any leaders out there. We are going to go into kind of a hub and spoke mentality. And what that means is that you will have a major region, and underneath that major region, what maybe was a region before will become a deputy commanding general, and the capabilities will actually support this major region, which will allow that region to align with regionally aligned forces and our corps, because that's our relevancy that's out there. And then the major region will align to supporting our combatant commanders. And then underneath that are regions, so like William Beaumont would be a hub, and the spokes might be Fort Huachuca or some of our other smaller commands, and then they would really kind of fall under William Beaumont, and it would be synchronizations of standards, of support, of capabilities and fundings. So we're going to look at hub and spokes across all of Army Medicine. And then we're also looking at some of our commands and saying, not our MTF commands, but some of our other commands, and saying, should those commands be directorates and service lines that fall under, as we've now changed how we're doing business at the headquarters. So that's what the Futures Task Force. It was not done to be a reduction in headquarters, but it will give us reductions in headquarters, because we do have a mandate for about a 25% reduction in headquarters. I have taken, just so that you know, most of the reductions are coming out of my headquarters, and we're not pushing that down to the lower levels, because that's where the work is actually done. So we are absorbing as much at our headquarters as we can, and that's part of why we need to operate differently as a MedCom. Yes. So that should be coming out in just a little bit. Okay, please. Yes.
You asked previously about patient safety and quality, and I have to say my little say.
Okay.
And you've met most of my staff in some of the other meetings, but from a smaller perspective, we take care of patient safety reports individually. The nursing staff does a great job of keeping up with that, and my patient safety manager do. And then we trend and analyze according to the 4068, and that gets reported up through the executive, the ECMS,
right,
the medical staff, the governing board, and then our PIPS meeting, which is the performance
improvement plan, right?
Meeting, which you've heard about. So that happens, the trending and analysis. We also have larger data, quality data, that I hope that you've been able to look at, because when our commander first got here, that was one of the things that I really bragged about to him, because even though we're stuck out in the desert out here, we have really good quality data. Our NISQIP data is excellent.
That's right.
Our partnership for patients data, I don't know if you've looked at any of that, but when the
I've looked at it, I don't have it off the top of my head, but I've looked at every MTF,
yes,
to be honest.
When the roll-up came up, ours was, we did not require any performance improvement. Ours was some of the best. Oryx, we are probably the best in the MedCom for Oryx, and that's because one of my Oryx nurse. And that, I have to say this, in spite of the CAG, which was the change.
When Centris roll out in April.
Oh, okay, okay, okay. When you say CAG, I think of Commander's Action Group, and so I was thinking, poor John, who's the leader of that. Sorry. Yeah, that's okay. That's why I was thinking. That's why you got the deer in the headlights from me. Okay. Okay.
Our Oryx, for Joint Commission, our Oryx numbers are usually 98%, and those are just the ones we report to Joint Commission. But she keeps track of every single one of the measures that MedCom reports on us, and we do an excellent, excellent job on that. And we were doing great before the Centris rollout. She had to completely, she and the physicians, and I have to give the physicians all credit for this because they worked very hard, and the nursing staff, because all of our documentation was excellent. It all changed when a Centris rollout came out, and she has had to completely change everything.
Okay.
And is still continuing to work on that, and she's gone all the way up to MedCom, to the top.
With that, okay.
Yes, ma'am. Carla Harry's and all of that. So in spite of all of that, we are continuing to do well with Oryx. She actually had Joint Commission stop looking at some of our measures for a quarter or two, just simply because of the chaos that
went into it. So one, I appreciate your dedication and leadership and the impact that it's having here, and in the entire team. I was not tracking the impact that Centris has had. I've got it. Doesn't mean my staff wasn't. It just means I personally wasn't. So I need to get a little bit smarter on that, because as we look at, you know, after the MHS review gets signed off by the SecDef, part of what we'll be doing is really looking at and saying, okay, where do we need to improve and what's the right improvement plan, and then where are we doing well. So we're already doing this. I've already actually have a spreadsheet in front of me, and I could tell you every one of my MTFs where they stand in every single one of those data points. And so our conversations now are, so tell me why William Beaumont is doing so well in this area. What are you doing that should be replicated across every one of our MedCents and MTFs? That's the conversation that we're going to start having our commanders have, so that we then make policy changes. And then maybe it's because we haven't resourced well. So maybe we need, you know, maybe workload has changed, and we have a, you know, a better system and alignment at one MTF than we do at another MTF, and it has to, and then we're not doing as good at coding at one MTF as we are as another. You know, so part of, just to let you know, part of what I've, when I talked with the Secretary of the Army in our preliminary data, and I just showed him and I said, sir, you know, these MTFs that are performing better than the benchmark, there are MTFs that are performing underneath the benchmark. It doesn't mean that there is poor quality of care being delivered. That's not it at all. There is a tie to coding, and there is a tie to how well we do in documentation and how well we do in coding. And that's an area that we've got to really, really kind of dig into. So what I want to make sure I get smart on now is what has truly been the impact of a Centris, and like what's that spike in your data of when that occurred, so that I can make sure that when I'm having those discussions within the building, I'm doing it from a much better informed position. So I appreciate you bringing that up. I would, one thing that I would ask though, and I shared this a little bit yesterday, I am personally, when we look at data anymore, I have personally changed my whole lens. And that kind of personal moment I'll share with you kind of came from twofold. One, we had a retired colonel who, this is back in another MTF, not yours, but who back in 2011 was being seen for a cervical neck injury, had an MRI. They noticed a vascular tumor, and so the clinician put in a consult, but never kind of followed through to see whether or not that consult was ever acted upon, and never told the patient. So 3 years went by, and the person was coming out of the MTF and got hit by a car, by a soldier who was just going a little too fast. And so broke her leg, broke her arm, and they did another MRI to see whether or not she had any, you know, traumatic brain injury. Well, she didn't have any traumatic brain injury, but what they found was a very large vascular tumor. And so she had to go in for surgery after she healed with her leg and her arm so she could get well enough to do that. And a recovery has been very, very complicated because of how invasive this tumor was. And I have to tell you, and she's a retired Army medical colonel, and her one call to me was not complaining about the system she loves. Hers was, ma'am, if there's an administrative error that happened, do you have confidence enough in the system that it's not happening again? And I thought, I don't. Because we don't have the systems in check enough to know whether every single administrative error, every single administrative procedure is checked and followed through. And there's other errors that we have that are preventable harm that occurs that we actually can prevent. And so it changed my whole lens in which I look at data, because I realized I have been personally okay with all the commands that I've commanded when we've hit 95%. I've never thought, what's happening to the other 5%? Not once. Never even crossed my mind. I really looked and said, wow, we are doing really well. The mark was 90 and we met 95%. I am so proud of this command. And I've moved my target to something else. And even at 98%, I never thought of who's the 2%. And when you look at, we take care of 3.9 million beneficiaries. So 10% of that is huge. And when we're not meeting the standard, we're introducing preventable harm. And we're okay with that. I think we, as an Army Medical Department, have to say to ourselves, every single time we come to work, we are going to ensure preventable harm doesn't occur, and that we're going to do the right checks and balance, and that we change that lens to the percentage that's really at risk. Because there's not one of us in this room, if we looked right now and we said, this side of the room is just had harm, risk at harm, this side's okay. If you're on this side, you're probably sitting there thinking, thank God. If you're on this side, you're a little unqueasy feeling and uneasy. And then you're wondering, okay, well, which one of us is actually going to be the one that's at risk? Which one is the harm? And then is that okay? Because that's a face that you now know that has a family, and you're impacting the person in the family. And there's not one of us that comes to work every day that doesn't come to work wanting to do their very best. There's no doubt in my mind. But every single day across Army medicine and across our nation, we allow harm to occur, and we don't even think twice about it until it's a catastrophic harm. And then we do the root cause analysis and we work to change that. But there's so many that we can actually prevent if we change the lens in which we're looking at. And that was a huge awakening for me personally. So I share that with you because I think that's what I want us to be leaders in. I want us to be leaders in having organizations that reduce the risk of preventable harm down to zero. And if everybody in the system focused on that every single day, I guarantee we'd be an organization that people would think quality of care, patient safety, and leading the nation in that area. And I think that's what we can do. We didn't accept anything that challenged us on the battlefield when it came to trauma. We saved lives that should have never been saved. And when someone talked about unexpected deaths, the conversation that we had in the Pentagon is it shouldn't be unexpected deaths, it should have been unexpected survival. Because we have soldiers that were quadriplegics that survived catastrophic injury on the battlefield and made it back through the entire system and are now living productive lives and received double-arm transplants. All of that came from Army medicine. It's pretty amazing. So if we can do that on the battlefield in the worst conditions, we can do that here. And I know that. And you're already starting in the best foundation possible. So I could not be more proud of what you do every day. I could not be more proud of the team that we have. And so thank you for the hard work. Thank you for really leading through the tough times of last year, of last year, and for making a difference. And so we got to keep this cohesive team and leading and really moving the ball forward. But I have no doubt we've got the right people to be able to do that. So thank you, and God bless each and every one of you.